which has taken the endoscopy community by storm over the last decade or so, and that is the invention and the practice of third space endoscopy. All of us know the immense advancement in interventional endoscopy, but this so-called third space endoscopy has been on the horizon only since the last decade. Now, what do we actually mean by third space endoscopy? Traditionally, for an endoscopist, luminal endoscopy is the first space endoscopy. Second space endoscopy is endoscopy which is done of the ducts which are attached to the lumen, that is of the bile duct and the pancreatic duct, cholangioscopy, pancreaticoscopy. Third space endoscopy is an endoscopy which is performed within the layers of the gut wall, that is within intramural endoscopy, that is in between the layers of the gut wall where this space is not actually existent. So this is a potential space. This space has to be created by the endoscopist. There's nothing in that space other than areolar tissue and a few blood vessels. And if you were to see this diagram, where exactly is the third space located? This is the mucosa, then we have the submucosa. Now you see here, this layer is the muscularis propria, and this is the muscularis mucosa. Now the layer between the muscularis mucosa and the muscularis propria is the submucosa. The submucosa is the third space. Now why did third space endoscopy at all become popular? Because the greatest fear in the mind of an endoscopist, whenever they want to do any resection in the lumen, is the fear of creating a perforation. If you want to remove a tumor, if you just cut over the tumor and try to remove it, and if the tumor is coming from the muscle, you will make a full thickness perforation. But if that tumor is submucosal, and you go in the submucosal space, and from inside you remove and take it out, you will not create a perforation. So the whole principle of third space endoscopy is to make a tunnel in the submucosa of the esophagus or the stomach or the rectum or wherever. And then whatever intervention you do in the submucosal space. The entire mucosal flap remains intact. So once you do your therapy and come out and close the mucosa, everything seals off and there is no perforation. Now this gave birth to various procedures. The invention came because of two animal experiments, one by Chris Gostout. Chris Gostout from Mayo Clinic showed that in animals, in pigs, live pigs, he could make a tunnel in the esophagus in the submucosa, then cut the muscle, enter the mediastinum, take a biopsy from the fat in the mediastinum, come out, close the mucosa, and all the pigs survived. Similarly, Pankaj Pasricha showed that you could enter the third space, the submucosa, cut the muscle of the esophagus completely, full thickness. So open the mediastinum, but leave the mucosa intact, and again close the mucosal incision. All the pigs survived. And this gave birth to the landmark procedure of per-oral endoscopic myotomy, or POEM, for achalasia cardia. And the first human study was done by Haru Inoi in Japan on 20 patients. Now, from the time POEM got invented, look at the number of procedures which were invented utilizing the third space. We have POEM for myotomy for esophagus. Then we have gastric pyloromyotomy, or patients who have got gastroparesis. Then STIR, or submucosal tunneling endoscopic resection of submucosal tumors. ESD, instead of doing a normal ESD, we can do a submucosal tunneling dissection and ESD. Then we can do a rectal myotomy in patients of Hirschsprung's disease by using submucosal tunneling. And we can also cut a diverticular septum, either in a Zenker's diverticulum or epiphrenic diverticulum, using the third space. Now, how is per-oral endoscopic myotomy performed? This is how it is done. Just 15 centimeters above the esophagogastric junction, you enter the third space. You make a small incision in the mucosa by creating a fluid cushion, and then put the scope through and through the submucosal tunnel, all along the length of the esophagus, across the esophagogastric junction, into the stomach. And then, once the tunnel is completed, you go in, and from inside the tunnel, you cut the muscle layer. Now, even if you have cut the muscle layer completely, once you close the muscle, the mucosa, at the entry point, the whole mucosal flap will seal. And from the time it has been invented, there have been more than 400 publications on POEM. 12,000 procedures of POEM performed in the world, 6,000 in China, 2,500 in Japan, 2,000 in our own department in Mumbai. And you see here, this is what we do. 15 centimeters or 12 centimeters above the esophagogastric junction, we are injecting fluid in the submucosa, either with a needle or by use of a hybrid knife. Here you are seeing a hybrid knife where the water comes out in a jet. And then once the mucosal cushion is formed, then you cut the mucosa. Don't cut the mucosa before the cushion is formed. If you cut the mucosa directly, you will make a full thickness cut and perforation in the esophagus. But after the cushion is made, when you cut the mucosa, you can actually see the muscularis propria, which is the lamina propria, below the first cut. And then by continuing the dissection, we rotate the scope and we enter inside the submucosal space. Now this is what you see inside the submucosal space. Once we enter the submucosal space, below you start seeing the muscle layer of the esophagus. And this is the areolar tissue in the submucosa. And on this side is the mucosa. And then by rotation of your scope from left to the right, depending upon how much big wide tunnel you want to make, you keep on cutting the areolar tissue, stay as close to the muscle as possible, and keep on advancing the scope in the longitudinal fashion until you reach the esophagogastric junction and then into the stomach. And thereby, we can make a very long tunnel. You see here, we keep on dissecting like this, and now this is how the long tunnel has been created. You see the long tunnel. On this side is the mucosa, which is completely intact. Here you can see the circular muscle fibers, and this is the white tunnel. Now, once the tunnel has been completed, then it's easy job to cut the muscle fibers. You can either do only a circular myotomy, or you can do a longitudinal myotomy. The length of the myotomy can be decided or depending upon the subtype of achalasia, whether it is type 1, type 2, or type 3. You can do a short cut, medium cut, or a long cut. If you have a jackhammer esophagus, if you have a tertiary contraction, or if you have a corkscrew esophagus, you can do a very long myotomy. Now here you see, once we do the myotomy, we actually enter the mediastinum. When you are doing a posterior myotomy, we can actually see the pleura of the lung. If you are doing an anterior myotomy, you can see the pericardium. It's important that when you do this cutting, the knife direction of cutting should be towards the tunnel, not towards the mediastinum. Of course, what is there in the third space are blood vessels. So as you keep on cutting, if you see any blood vessel, prophylactically, we have to catch the blood vessel and we have to ligate it and coagulate it using the coag grasper. And this way, we can perform a complete, accurate, fiber by fiber myotomy, depending upon the subtype of achalasia, and do a very effective procedure for the patient who has got dysphagia. After the procedure is done, once the myotomy is complete, all that we have to do is to pull the scope and close the 1-inch long mucosal incision, the place of your entry point, by multiple clips. And by using these clips, we can create a watertight closure of the mucosa. And 24 hours later, these patients can be started on a liquid diet. You see here, meta-analysis recently conducted 36 studies on POEM procedure, significant reduction of LES pressures, IRP, height of timed barium. The only problem was a possibility of reflux. Why? Because the anti-reflux mechanism, which is contributed to by the lower esophageal sphincter, now you have completely destroyed. However, the crural mechanism of the diaphragm still is intact. And therefore, after POEM, every patient does not develop GERD. Why? Because the crural mechanism is intact. Whereas, when you do a laparoscopic Heller's myotomy, you have to dissect out the diaphragmatic crura. And therefore, every lap myotomy has to be added with a door of fundoplication. In fact, you see a comparison between POEM and lap Heller's myotomy. Virtually, there is no difference in the success rate. The only thing is that symptomatic GERD with laparoscopic Heller's is significantly lower as compared to the POEM procedure. In fact, POEM has become so popular now that this is a paper published from a thoracic surgical unit from United States, Demister's unit, you see here. And the conclusion of the paper was thoracic surgeons with an interest in esophageal diseases are encouraged to adopt the POEM procedure. So thoracic surgeons themselves now recommend that POEM is the right technique. Third space, I told you, can also be used for removal of submucosal tumors. You make a submucosal entry, go in the submucosal space and dissect out the submucosal tumor from inside, literally as if you are doing underwater swimming. You see here, this is a submucosal tumor, leiomyoma in the esophagus, causing dysphagia. So a little bit proximal to the submucosal tumor, we enter in the third space, we keep on going ahead. As we keep on going ahead, we start seeing the tumor. Once we see the tumor, we dissect the tumor out anteriorly from the mucosa, from the sides from the areolar tissue, and posteriorly from the muscle. And by doing this, the entire intact tumor can be taken out through the mouth without having the need to do a thoracoscopy, mediastinoscopy, or a thoracotomy. Now, this can be achieved without doing a full thickness perforation only because we have utilized the third space. Again, you see here good data suggestive that stir procedure is extremely useful. Similarly, third space can be used to perform a pyloromyotomy. Imagine directly cutting the pylorus of the stomach. You'll again create a full perforation. But the same pyloric muscle can be cut in those patients who have idiopathic gastroparesis or diabetic gastroparesis or post-operative gastroparesis. And few centimeters proximal to the pylorus, we again make a fluid cushion like this, and we can go inside the submucosal space. We keep on proceeding, pushing the scope ahead towards the pyloric ring. And once you see the ring, this is the ring you see here, then we use a special knife which is called as IT knife, hook the knife beyond the pyloric ring and pull it back, and thereby fiber by fiber we can do a antropyloromyotomy. And in those patients where you have proven that they have gastric emptying, which is impaired on nuclear studies after doing a GPOEM or a gastric pyloromyotomy, we have shown that there is a reasonably good success. You see here normalized gastric emptying scan in almost 90% of the patients with an improvement in 85%. Many of you are aware that ESD, which is routinely practiced in the East, is endoscopic submucosal dissection of early cancers, where you cut around the early tumor and you cut it. And ESD procedure, because you cannot triangulate, you cannot retract and cut, it takes a very long time. But if you use the third space technique, ESD also can be done fast. So instead of just cutting the early gastric tumor, early squamous cancer in the esophagus, we make a tunnel below the cancer, multiple tunnels, and then we join the tunnels, and by this, a procedure which would have otherwise taken 4 or 5 hours now can be completed in as short as a few less hours. Now, this is how we dissect a septum, which is there, which is causing dysphagia in patients of Zenker's diverticulum. One of the endoscopic techniques is to directly cut the septum. But the limitation is you can't cut the septum completely. If you cut it completely, you will make a leak. There will be a leak in the neck. But for you to enable you to cut the septum, we can make a tunnel in the pharynx. So we can make a tunnel in the pharynx, and we go inside towards the septum, and here you can see how beautifully the muscle of the septum is seen through the third space. And then, because now you have utilized the third space, you can cut the septum right till its base. And thereby, you can prevent recurrence of dysphagia after doing such type of a septotomy, which is done endoscopically. All of you know that POEM can cause GERD. In fact, that was the only criticism of POEM. And I also told you that for this we can use the instrument of Gerdex, that is a full thickness plication. But a very new technique which was recently invented by Professor Inouye, he described that during the POEM itself, endoscopists themselves can perform a fundoplication. They do an anterior myotomy, push the scope beyond the lower esophageal sphincter, then go beyond and go into the peritoneum with the scope, see the fundus, pull the fundus inside the tunnel and attach the fundus inside the tunnel by loops and clips. Now this is called POEM F, POEM with fundoplication. The only problem is this procedure, in all patients, we have to do an anterior tunneling. If you do posterior tunneling, you cannot enter the peritoneum. So we have to do an anterior tunnel, and in all patients, you will have to do a fundoplication. You cannot predict beforehand who will develop a GERD or no. So therefore, this is a very new procedure. I will quickly show you. I'm not going to show you all the videos, but just the last video where you can see how the fundoplication is done. And this is how the entry is done into the peritoneum. Now we have gone here, we have gone inside. You can actually see the liver. We have passed the scope outside into the peritoneum through the submucosal space. And below you can see the fundus of the stomach. Above you see the left lobe of the liver. We catch the fundus of the liver, fundus of the stomach with a forceps, pull it inside, and you can actually see when you pass another scope into the stomach how nice it appears like a fundoplication. So you can catch the fundus, pull it inside, and attach the fundus in the tunnel itself by using a series of clips and loops. This is a very new procedure. The durability of this procedure is under question. So presently, for those patients of POEM who have got reflux, we prefer to perform a full thickness plication. Endoscopists, because of all these techniques, have become more and more bold, and you will not believe it, but already endoscopists have started entering what we now call as the fourth space. And the fourth space is performing procedures inside the peritoneum. This is a patient of symptomatic gallstones who vehemently was against undergoing surgery, and he was ready to sign any consent form. So we decided to go ahead and do a fourth space endoscopy through the rectum. So we performed a tunnel in the rectum, passed the scope inside the peritoneum. We went to the gallbladder. There is a cap which is attached to the tip of the scope. Then we are making a hole in the gallbladder by using a hook knife, and by enlarging that hole, for that we use a IT knife, and then pass the entire scope inside the gallbladder. You see here, now we are entering the gallbladder by rotatory movement. You can see this is the internal part of the gallbladder. You can see multiple stones here. So we catch all the stones using a rock net, take the stones out, take them out of the rectum, and we close the gallbladder by using a series of clips. This is against traditional thinking. This is against traditional teaching. However, let me tell you, this was a procedure we did 4 years back. Till now, this patient is completely asymptomatic. All that we did was only removal of gallstones. He had a functioning gallbladder, and the pain reduced, pain completely went away. Patient never developed another attack of cholecystitis, and these clips did not give any trouble. So this is thinking not only out of the box, but thinking as if there is no box. So therefore, friends, ladies and gentlemen, diagnostic endoscopy has evolved to therapeutic endoscopy, but the time has come for us to enter into a completely new field, and that is flexible endoscopic surgery. So whether you are a gastroenterologist or whether you are an endoscopic surgeon, there is a new field which is going to evolve in the future, which is high time those of you who want to do advanced intervention need to start adapting to it, and that is flexible endoscopic surgery. Because very soon, such type of a scope is going to come into the market, and this is going to be a multi-armed robotic endoscope, where by utilizing the third space, utilizing the fourth space, you can use all these arms. You can have excellent triangulation, and you can actually perform a surgical procedure not only in the lumen, but in the third space, but also probably in the fourth space. All said and done, I want to only quote two sayings, one of Peter Cotton, where he said many years back that as an endoscopist, as a clinician, as a gastroenterologist, instead of only thinking of the whole, you have to think of the patient as a whole. And more importantly, when you do these advanced techniques, you have to be like a good mountaineer who knows how to come back safely. Every procedure that you do, there should be a way, some time where you will be able to return back safely. You should never take an irreversible step and land yourself in a situation which will create a major complication. Thanks for your attention.